Hi everyone, welcome to POC Nurse. My name is Gozi, and in this video, I want to talk about some assessments that I had to do when I was a home health nurse. If you didn't do those assessments or you didn't answer those questions, you couldn't close out your chart. And those assessments are as follows, and in no particular order, really. We always assess for UTI, we always assess for constipation, falls, medication, and nutrition and hydration. And I'm coming at this topic from kind of a safety standpoint because if the patient has all some of these conditions and they go untreated, it could be harmful to the patient. So, first thing I want to talk about is the UTI. So every time I went and saw a patient, I had to ask them if they had, signs and symptoms of a UTI. That's a urinary tract infection. So I would ask the patient if they're making urine, how many times a day they are making urine, and then I would ask if they experience any discomfort when they go to urinate. And depending on what they say, um, I usually almost always will teach about what a UTI is, signs and symptoms of a UTI, and complications of a UTI, so that they can understand, why they need to look out for this problem and what to do if they notice any of the signs and symptoms so that we can kind of get ahead of it. So I would say to the patient, here are some signs and symptoms of a UTI. You could get some pain and burning when you go to pee, or have some discomfort when you go to pee. You could feel like you're not fully emptying your bladder. And if they have a family member, I would also teach about atypical signs and symptoms of a UTI, which could include altered mental status. I will tell them the patient may or may not have a fever, but these are just a few things to look out for. I would also teach them about the character of the urine itself. Is it foul smelling? Does it look cloudy? Does it look off? You know, and I'll teach the patient, if you notice any or all of these things, call the doctor. If the patient is altered, take the patient to the hospital. And I would like teach the patients to, regardless of what you do, always make sure that the doctor is aware. And then, the patient might look at me like, why am I wasting their time? And then I would go into the complications of a UTI. I would tell them, if the UTI is left untreated, it could develop into sepsis. And sepsis is a life threatening infection. People die from sepsis. And, you could do this little thing to prevent this big thing from happening. And, they will be cooperative. So, I think that's pretty much it with UTI. So I would usually teach signs and symptoms, complications, possible complications, and what to do if you feel like you have a UTI. If you suspect that you have a UTI, go to the hospital, call your doctor. All right. So that's it with UTI. The next thing, I usually try to get like all the bathroom stuff done together. The next thing I would talk to the patient about is constipation. I would ask the patient, are you having bowel movements? How often are you having bowel movements? Are you having any trouble having bowel movements? Are you constipated? Are you straining when you go to the bathroom? And depending on what their answer is, I would teach them the same thing, signs and symptoms of constipation, possible complications of constipation, and what to do if you feel like you are constipated or are actually constipated. So I'm saying all these things in no particular order. So I've had a patient that complained of constipation, several patients. And so what I would do initially, I would go through their medications to see if they have a stool softener. Because I've had patients that had stool softeners, they weren't taking it, and then they were complaining of being constipated. So I'd go through their medications. If I find the stool softener, I'll tell them, okay, your doctor has prescribed these stool softeners. And the agency I worked with had a protocol. We were to teach the patient to take the stool softeners for 2 days. And if they didn't have any relief, they were to call their doctor and let the doctor know. So maybe the doctor could prescribe something stronger. So I would teach them that. I would teach them, of course, signs and symptoms of constipation. You're straining to go, or you haven't had a bowel movement in some days. And then I would teach them complications of constipation. I would teach the patient, you could get fecal impaction, you could get bowel obstruction, and bowel obstruction needs surgical intervention. You'd have to go to the hospital. A surgeon would have to kind of go in and treat that bowel obstruction surgically. And surgery, there's risk of infection, there's risk of damage to surrounding organs. So, again, to prevent this big problem, there's this little thing that you can do. So I would teach the patient about constipation in that way. And if there's a family member there, I would also make sure to teach the family member about constipation, about the patient taking their stool softener if it's already prescribed. And something else I will I did was, once I found out the patient was on any kind of opioids, I would teach about constipation as well, because the side effect of opioids is constipation. Next, I will teach the patient about falls, or ask about falls, or assess for falls. So I would ask the patient, have you had any falls since the last time we were here? Even like a near fall is considered kind of a fall as per my agency policy when I worked. So whether the answer is yes or no, I would look around the patient's home for any possible thing that could cause a fall, or even think about the patient's medication, nutrition status, their gait, things like that. They steady on their feet or not. So I would assess the patient's apartment and be like, okay, I see that you have things in the way, in the pathway where you walk. These things could cause you to fall. So that pathway needs to be clear so that you don't fall. If the patient's bathroom is too far away from where they sleep or where they sit, I'd be like, your bathroom, your this is far away from you. And if you have to pee and you're kind of in a hurry to go pee, you could fall. You could get a commode and put it next to you so that you can, if you need to pee, you just get up and use the commode right there, put it next to you wherever you usually stay, in the bedroom, in the living room, where it doesn't matter. The goal is to try to prevent falls. So now I teach the patient, well, if you have a fall, it won't be good, because, you know, there's certain complications associated with it. When you fall, you could hit any part of your body. You could hit your hips and get a fracture. You could hit your head, brain bleeds, so it's kind of a big deal. And the patients, for the most part, usually will pay attention to the fall part. So maybe because they've had falls in the past, they have family members that have fallen and were really hurt, but they're usually good with the fall education, the patient themselves and their family members. Once I start, they're going to be like, oh, we have grab bars. We clear this place. We make sure this is available, that's available. We don't want, our loved one to fall. So that's another thing. We always had to ask the patient, and we always had to, in my care plan, fall prevention was always there. Fall prevention, the UTIs and the constipation was always there. Um, the next thing I would talk to the patient about is their medication. So in the tablet, you always have to ask the patient, do you have any new medications that your doctor prescribed? And you have to do like a medication reconciliation. So if it's the first time I'm meeting the patient, I will usually go through the medications, and I would ask the patient, I just assess to make sure that they're taking the medications right. Because if they're not taking it properly, it could hurt them. I've had a patient that was discharged from the hospital, and all of her antihypertensives were discontinued. So when I ask her to bring me her medications, she brings me, beta blockers and its inhibitors. And I checked her blood pressure. Her blood pressure, it was like 90s over something. And I'd gone through the chart, and she herself had told me that, her doctor told her to stop her antihypertensives. In the hospital, they called a rapid response because she was hypotensive and bradycardic. Now I ask her to bring me her meds, and she brings me, um, I think, lisinopril and some beta blocker, metoprolol or something. And she tells me this is what she's taking. Oh my God. I said to the patient, well, you're not supposed to take these two. Okay, you just told me your doctor asked you to not take the antihypertensives. I read your chart, and this is what happened with you in the hospital. And the hospital doctors took you off of your blood pressure medications. So you are not going to take these blood pressure pills anymore. And she was like, oh, she did not know these were her blood pressure pills because someone had moved her pills around and put this with the batch that she's supposed to take. My goodness. And there was someone else there. I told the person she's not supposed to take these medications. I also called the patient's doctor to confirm, and they confirmed as well. I called the pharmacy. I let everybody know, because if she continues, and I think she fell. She went to the hospital because she fell, or she almost fell, or something like that. Because if the patients are not taking their medications correctly, it puts them at risk for fall. So this patient could get hypotensive, she could get dizzy, and she could fall. She could fall in such a way that she could get seriously hurt. So, medication safety is super important. I had another patient that was on insulin, and she wasn't sure how to take her insulin. She'd just been discharged from the hospital. So I was doing her admission. So she wasn't sure how to take her insulin. I looked at the discharge paperwork. It was listed there, but her family member wasn't sure if the hospital had it right. So I said, no problem. I called her doctor's office. They didn't really give me that much information. So I found out she has an endocrinologist. I called the endocrinologist. It was awesome. I called the endocrinologist. He picked up the phone. He actually knew the patient, and he went to her chart and broke down all of her insulin regimen for me. I wrote everything down and wrote it down for the patient, because the patient's family member had told me that she had an incident where I don't know if she took her insulin some way, somehow, something happened. Her blood sugar was low. So then she started eating all this food. Now her blood sugar is high. So now she's taking all this insulin. So, you know, we went through all of her insulin. I taught her, we did education on how she was supposed to be taking it. We actually did a chart and put it on her fridge of how she was supposed to take her insulin. So that was good. And that's the thing about medication safety. I always assessed what medication the patient had, and I made sure they knew how to take their medication, especially their high risk medications, the insulin, the antihypertensive, anticoagulants, the narcotics, opioids, things like that. And especially with like the opioids, I would always teach about constipation with the opioids, and I would check to see if the doctors prescribe the patients two softeners with the opioids. And 9 times out of 10, they would have a stool softener prescribed to go along with the opioid if they're going to be taking that opioid for a long time, like chronically. If it's like a patient that just takes it here and there, they sometimes wouldn't have a stool softener um, prescribed, and there was always like an end date to that opioid use. So that's it with medication safety. Next thing I want to talk about is nutrition and hydration together, and then I'll kind of tie everything together at the end. So I've had a patient, he had a Foley, and very jovial guy, very nice. I would go see him, and he was so pleasant to take care of. And one time I went there, and this guy is like not cheerful at all. So I'm like, what's wrong? And he's like, I feel nauseous. I'm not eating. There's this medication I'm taking. It makes me feel terrible like this, and I don't want to eat. And there was always a family member there when I saw this patient, and the family member was like, "Yeah, even his urine. I looked at the Foley bag. She said he doesn't make as much urine as he usually does, and he's dark." So then I had to teach about nutrition and hydration. So I said to the daughter, "Well, this medication is actually affecting his nutritional status. It might be causing some malnutrition because if he takes this medicine and he gets nauseous and he doesn't eat or he doesn't drink, it could lead us to other problems. If he doesn't drink, he could get dehydrated. And dehydration itself comes with electrolyte imbalances. If he doesn't eat, he might get, malnourished. We talk about muscle wasting, weakness, and all of that puts him at risk for falls also. And even the dehydration can cause hypotension. So I said to her, "Well, maybe we can call the doctor and see if he can stop the medication if it's not required, or maybe he can take the medication kind of at bedtime when he's done with like all of his eating for the day." Call the doctor. Um, the doctor didn't really stop the medication, but I believe that patient started taking the medication at a different time so that he could, have his fluid and meals for the day before now taking the medication. Because it's important for the patient to have their to eat, especially the patients that have wound, not only to eat but eat all the right things, and also for them to drink enough fluids. Like I said before, they get dehydrated. It might lead to hypertension, electrolyte imbalances. They get malnourished. It could lead to muscle wasting, cachexia, and weakness. you know so these are the five things that I used to have to assess when I was a home health nurse. For UTIs, I used to have to assess for UTIs, constipation, falls and falls prevention. I used to have to do medication reconciliation, and I'm putting in on here for kind of like safety, nutrition and hydration status. And I think all of these assessments we need to do for the patient's safety as well. Because if any of these go untreated, unchecked, unassessed, the patient could get hurt one way or the other. They could fall and get hurt. The whatever the issue is could progress into something that's life threatening and could cause them to go from someone who's independent to someone who's dependent. So, yeah, that is it with this video. I hope someone finds it helpful, and I'll see you in the next one. Bye bye now.